Thank you very much for joining. We will just wait for a minute or two for the rest of the colleagues to join, and we will begin our webinar shortly.
Hello, do you hear me? Hello.
Yes, we can. Yes, we can hear you, Dr. Chamla. Good morning, and thank you for joining. Good morning, colleagues, and thank you very much for joining our webinar. On behalf of the organizers, I warmly welcome you to this important webinar on strengthening integrated influenza surveillance with a particular focus on data for preparedness. We're very pleased to see each one of you participating today. On the panel, we have the Program Area Manager for Emergency Preparedness, Dr. Dick Chamla. We also have Dr. Lionel Nizigama from WHO AFRO, Dr. Cedric Batiano from WHO HQ, as well as Dr. Stefano Tempia from the Task Force for Global Health. I am Linda Nyasha Kanzara, and I am with WHO AFRO. We're also very pleased to have country focal persons who will be presenting on the country spotlights on the progress of the work that they've been doing. And I'll be co-moderating this session with Dr. Lionel. Please note that this session is guided and adheres to the WHO standards and code of conduct, and some key points on housekeeping. Interpretation is available in English, French, and Portuguese. Can we have the slides moving, please? Interpretation is available in English, French, and Portuguese. And there is a question and answer function which you can click on for topic-related questions, and the chat box which you can use for introductions and any other related logistics. On that note, I will kindly ask all of you to please just introduce yourselves using the chat box, indicate your name, where you are dialing in from, as well as your function in your respective country. If you'd like to take the floor, you're reminded to kindly raise your hand and one of the panelists will attend to you. This session is being recorded and materials, including the recording, will be shared afterwards. Our session will run for 1.5 hours and we aim for it to be interactive and engaging. Before this session is officially opened, the key objectives are to enhance the quality and use of influenza Sentinel surveillance data with a focus on data for preparedness. Some of the terms that you will hear today include pandemic influenza severity assessment framework, as well as burden of disease estimation, which may be new to some of you. But by the end of this webinar, we hope that these concepts will become much clearer and you will see how they directly strengthen preparedness, particularly where respiratory diseases are concerned. At this juncture, I shall invite Dr. Chamla to officially open this webinar. Dr. Chamla, thank you for joining us. The floor is yours.
Yeah. Okay, I will be apologizing because I am now traveling for another mission and I am in the middle of another mission, another meeting. So I wouldn't be able to really stay in the whole of webinar. But I had to attend the webinar because I think the issue of pandemic influenza in Africa is becoming critical. And as I'm speaking now in the WHO globally, there are a number of initiatives in which have started to ongo. including the partnership with other actors in the research on H5. So I think the reason it's so critical at our level in the leadership to come and actually, offer this opening remarks in order to show our appreciations of the efforts in which are already ongoing, and also appreciate our member states who are part of the PIP framework. So after having this preamble, I will start with my opening remarks. Good afternoon, colleagues, partners, and distinguished participants. It is my great pleasure to welcome you to this regional webinar on strengthening integrated Sentinel surveillance of influenza and other respiratory devices. I would like to begin by expressing my sincere appreciation to our speakers for sharing their expertise today, and to the AFRO-PIP team for convening such an important and timely meeting. Our region has made significant progress over the years in building and expanding Sentinel surveillance under frameworks such as Global Influenza Surveillance and Response System, GISLI, and the PIP framework and IDSR. More recently, we have seen new countries joining the G3's network through the establishment of Sentinel surveillance, including examples such as Lesotho and Congo. We have also seen a growing number of countries contributing to pandemic influenza's severity assessment reporting, among them such as South Africa, Madagascar, Cameroon, the Guinea, and Nigeria, in which it demonstrates commitment to providing timely and quality data. Similarly, the ongoing work on the burden of influenza and the disease estimation is on horizon, and here in AFRO, I think we all appreciate your efforts on this. So, and as well as we've seen ongoing and sustained engagement from countries such as South Africa, Kenya, and Ghana, and more recent effort from Togo, Burkina Faso, Mauritius, and others. These examples reflect the collective progress across the region, yet we know that the value of these investments lies not only in collecting data, but in using it. Data for preparedness must be our guiding principle, enabling us to anticipate trends, prepare for local epidemics, and take timely actions in the face of emerging threats. A routine surveillance, Sentinel surveillance, is the foundation of this approach. It is through continuous high-quality data that we can detect unusual patterns, set evidence-based thresholds, estimate disease burden, and make informed decisions to protect our population. Opportunities remain for every country to further leverage their surveillance data, not only to meet global reporting requirements, but to strengthen national and subnational preparedness. And as we have learned from recent history, the next pandemic is not a question of if, but when. As we engage in today's discussion, I encourage each one of us to share successes, our challenges, and our aspirations. And let us continue to collaborate, innovate, and build the resilience needed so that when the next threat emerges, the African region will be prepared. I will be looking forward to the outcomes of this discussion, and I will be standing by here from AFRO to see how we increase our support to our member states. In conclusion, from my side, I think one of the issues in which in Africa, and even we have been talking in a number of times here in the WHO, is how are we able to increase awareness of the burden of influenza in Africa? As we're speaking now, the a perception out there is that influenza is not the public health issue, in which it requires an attention at higher level, political and including our donors. So our homework for all of us in the call and the people experts is actually to let us know, to create the evidence in which it will enable our politicians to appreciate the importance of increasing investments in pandemic or in influenza programs in Africa. So I would really appreciate your attention to my opening remarks, and I'm wishing you all the best. And I'm returning to you, the moderator, to continue for the program. Over.
Thank you very much, Dr. Jamla. We appreciate you setting the tone and really emphasizing the need to be able to use our surveillance data for informed programming and policy making. As indicated earlier on our agenda, we are going to have two presentations coming up next. The first one will be by Dr. Cedric Bationo, and he will present on the Pandemic Influenza Severity Assessment Framework. In this presentation, he's going to outline what it is and how we can leverage our Sentinel surveillance data in order to make use of this framework. Dr. Cedric Bationo, please, the floor is yours now.
Thank you, Linda. Can you hear me?
Yes, loud and clear.
Thanks. So, good morning, everyone, and thank you for joining this webinar. I'll be presenting the Pandemic Influenza Severity Assessment, or PISA. It's a WHO framework designed to help countries assess the severity of influenza activity during both seasonal epidemics, but also pandemics. Next slide, please. So PISA was first developed after the 2009 influenza pandemic, and when it became clear that countries needed a more systemic way to measure and communicate severity. And the very first WHO guide was published in 2017, and the second edition came out in 2024, reflecting some of the lessons learned and the new best practices. So the idea is simple, is to provide countries with a flexible, standardized tool that can be used for weekly and end of season assessments. And these assessments not only are informing national decisions, but also feed into regional and global understanding of influenza activity. Next slide, please. So in short, PISA aims to answer two key questions. How would you characterize current influenza activity? And how does it compare with past epidemic or pandemics? So by using historical data to calculate thresholds and comparing those thresholds with your current activity, PISA helps countries to describe and interpret and contextualize the epidemiological situation, visualize seasonality to improve the communication, inform risk assessment at all levels, and also support public health preparedness, response, and recovery. And PISA can also help guide resource allocation, ensuring that the right interventions are deployed at the right time. Next slide, please. So now we talk a little bit about the terminology of PISA. So to make PISA practical, we rely on three key building blocks. So first, we have the data sources. So this is where the information comes from, such as the Sentinel surveillance, the participatory surveillance, space socialism, and then all that. Then we have the parameters. This is the actual data points we use. So it can be ILI cases per 1,000 outpatients, for example, SARI admission per week or ICU occupancy for influenza patients. And we have the indicators. These are the dimensions of severity that we want to assess. So PISA also focuses on four dimensions to the indicators. So we have the transmissibility, we have the seriousness of disease, we have the morbidity and mortality, and then we have the impact on healthcare capacity. And together, these elements allow us to structure and interpret the complex surveillance data in a standardized way. Next slide, please. So we talk about the 4 steps of PISA here. So PISA follows a straightforward 4 steps process. So the first one is to select the parameters from an existing system to inform the indicators that we just talked about. And then use historical data to calculate the thresholds, interpret the data using those thresholds that we calculated, and finally report and communicate the results. Next slide, please. So now we talk about the indicators and parameter selection. So countries can decide whether to use influenza-specific indicators or broader syndromic indicators, depending on the systems they have in place. And each indicator can be informed by one or multiple parameters, as we see here. For example, transmissibility would be measured both by the percentage of, for example, the percentage of influenza positives among ILI cases, or by only using the absolute number of influenza detection. So the key point here is the more parameters you use, the more nuanced and robust your assessment become. And then you can see on the visual here that it's only the seriousness of disease that is always influenza specific. And then the other 3 indicators can be influenza specific or syndromic. Next slide, please. So talking about the parameters, those need to meet clear criteria. So they must be reliable, collected consistently over time, available weekly, and also the denominators should be available to be able to calculate the proportions of the rates. And if you have your data stratified by age, this is also helpful. Next slide. So now we have tables with examples of parameters that we can use for each of the indicators. For example, the transmissibility one. So the transmissibility indicator is assessing the level of community transmission through presentation with mild illness. So typically, this is the first indicator to detect increases in activity. So it's useful for a timely assessment of the beginning of the season. And then in the table here, you have a few examples of parameters that you can use to assess this indicator. Next slide. Then we have the morbidity and mortality indicator. This one is assessing the level of severe disease and death. And then also we have a table with examples of parameters that we can use to assess this indicator. Next one. The third one is the impact on healthcare capacity indicator. This one measures healthcare demand relative to capacity. And this indicator is affected by the changes to total capacity. For example, if we have a surge capacity that is engaged. And then also we have a table where we have examples of the parameters that can fit into this indicator. Next slide. And we have the seriousness of disease indicator. The parameters that feed into this indicator are ratios or proportions, which reflect the fraction of cases which result in a severe outcome. So for this one, due to the possible lag between hospitalization, ICU admission, and registration of death, we use the cumulative data since the start of the epidemic wave. And then as cumulative data is used, the seriousness of disease should be reported up to twice per epidemic. So you can report once around the peak and then another report at the end of the epidemic. But it's fine if you only report it once a year. Also, if you have age stratified information on high-risk group, you can also use that to interpret this indicator. And then again, you have a table with a few examples of parameters that can feed into this indicator. Next slide. So now talking about setting the threshold. So this is a central feature of PISA. So we have two types of threshold here. We have the epidemic threshold, which is also called the seasonal baseline. This one signals unusual activity outside the expected period. It can be also at the expected period as well. And we have the intensity threshold, which now classify the weekly activity levels that we have into categories. So we have the low, the moderate, the high, and then the extraordinary levels based on historical peaks. So to do that, like I said in the beginning, we need to analyze multi-year influenza surveillance data to understand the typical seasonal pattern and to define the different levels of influenza activity. And really the purpose of that is to be able to describe qualitatively the activity using defined levels. That way, we can easily communicate about the situation of influenza. And this threshold as well guide data-informed decision for public health interventions to ensure that they are proportionate. Next slide. So here we show an example where we see that by placing your current data into historical context, countries can communicate clearly about severity. For example, here we can say that this season influenza activity reached a high level and it's more severe than usual. Or we can say that this week activity is below the baseline levels, indicating that we are in a post-epidemic phase. And then we think that this kind of language is really important for decision makers and the public. Next slide. So we have many countries that are already applying PISA in the national reports. For example, we have Scotland, we have Chile, England, South Africa that have adopted the approach to contextualize the influenza activity. And most importantly, we always say that PISA is not prescriptive. So it's designed to be flexible, allowing countries to adapt the methods, but also the reporting style to their own system and capacities. Next slide, please. So now talking about reporting PISA to WHO. So countries that send that use PISA, do not send raw data to WHO. So they report weekly indicator scores and the contextual information. Then WHO uses this data to produce global assessments which provide countries with insight into what's happening in neighboring countries or globally. And in return, the member states also benefit from seeing how their own data compares to international patterns, strengthening, the preparedness and resource planning. Next slide. So now we talk about minimum data required to do PISA. So an important point that we already talked about is that PISA does not require new data collection. So it builds on what the countries already have. And the minimum requirement is just one surveillance parameter. So for example, ILI or SARI data is sufficient to do PISA. And of course, using more parameters allows for a more comprehensive assessment. And to set the threshold, at least 3 years of historical data is recommended, since I think that gives you enough perspective to distinguish normal variation from unusual activity. Next slide. So the key messages from this presentation will be that PISA assesses influenza activity across 4 main indicators. So we talked about the transmissibility, the seriousness of disease, the morbidity and mortality, and then the healthcare impact, right? And it requires at least 3 years of reliable and timely historical data. And PISA helps countries to get more value out of the existing surveillance system by putting the current activity into historical context. And finally, reporting PISA output with WHO will improve our collective understanding of global influenza activity, which I think is essential for preparing for the next pandemic. Thank you for your attention.
Thank you very much, Dr. Cedric. That was a very insightful presentation. I just want to remind participants that feel free to send through some questions if you have any through the question and answer box. And if there are any logistical challenges with relation to interpretation, also indicate that through the chat box. At this juncture, I will call upon Dr. Stefano, who will give us an overview and some insights on the burden of disease estimation. Again, this is another key area that we are looking at when we're looking at our data for preparedness, specifically for influenza sentinel surveillance. Dr. Stefano, the floor is yours.
Thank you very much, Linda, and good morning and good afternoon to everyone. I am Stefano Tempia, and I'm currently consulting for the Task Force for Global Health. My background is in epidemiology, and today I will be talking very briefly about why estimating burden of influenza disease is important. Next slide, please. So usually the studies related to estimating the burden of a disease, whether it is influenza or the respiratory viruses or other pathogens, are really conducted as a study. So within a very specific time frame, and usually it leads to publication in peer-reviewed journal. But the purpose of implementing these studies related to burden of disease is not really to publish only, and that's why I put at the top of this slide that the influenza burden of disease estimation should not be an academic exercise. The results of these studies will really be used to implement, to inform policy to control the burden of influenza disease. I want to start by saying that seasonal influenza epidemic can lead to severe economic drops and loss of workforce productivities. We all know, however, that influenza is a vaccine-preventable disease. Nevertheless, influenza vaccine is grossly underutilized in Africa, but also really across the world. So here, under this context, is where the estimation of influenza burden of disease came into play, in that influenza burden of disease estimation can inform evidence-based policies. And there is really a continuum in terms of generating evidence to inform policies that can impact the health of people. And the first step, one of the first steps, is really to estimate the burden of the disease. Next slide, please. When we talk about informing policy, we usually consider two different layers. The first one is the one at the bottom, at the top of these slides, which is generating the evidence. It is very hard for a policymaker to make a decision to implement, for instance, an annual vaccination campaign against a disease if they don't know how much health problem this disease causes in the populations. And the second aspect is really to understand the barriers that are associated to potentially the implementations of these control interventions once they become available. And if we talk about generating evidence, as I mentioned already, the very first step is to estimate the disease burden. For disease burden, we really mean to estimate what is the total number of illness that the virus causes in the population of a given country, which is very different from the data the great data and very important data that you obtain from Sentinel surveillance, because the data from Sentinel surveillance are really limited to a few Sentinel, either clinics or hospital in general in one country. And in many cases, even all the patients that present to this facility and meet the recommended surveillance case definitions, should it be ILI or SARI, not all these patients are usually enrolled in surveillance, whereas the estimation of the burden of disease really aims at getting to the total number of illness that one may expect to experience in the country in a given year or in multiple seasons of influenza virus circulations. And so this is really the first step of generating the evidence, really understanding how much illness, both mild and moderate, severe, and deaths, is due to the influenza. And then you can move stepwise in the process of generating evidence, like when you have estimate of the number of illness due to influenza, you can estimate the cost associated to this illness. So we are talking here about the influenza cost burden. And then if you apply interventions to mitigate both the health and the cost burden due to influenza, you can estimate how the impact of this intervention. For instance, vaccination campaign. If you start a vaccination campaign, how much illness and how much illness you are going to prevent, how much cost you are going to reduce. And so you can talk about impact of vaccination campaign. You can move further to estimate the cost effectiveness of influenza vaccinations and move along the path. Second part, which remains very important to understand, are the barriers. For instance, if a vaccination campaign is proposed in one country, it's very important to also understand, for instance, the acceptance of people of this vaccination program, how much the people know about influenza and the benefit of potentially vaccinating, so that your vaccination campaign can be successful. Next slide, please. So this slide is really drawn from a schematics that is available in the influenza strategic plan published by WHO, which summarizes what are the advantages of having a seasonal influenza vaccination programs, which can be multiple. In the first box, obviously, seasonal influenza vaccination programs will result in reduced burden of disease across different levels of severity. So it can prevent deaths, it can prevent hospitalization, it can also prevent disease transmission and missed work days. The second big advantage of having a strong seasonal influenza vaccination program is that on its own it strengthens the health system. And this can be done in different ways. For instance, through improving cold chain facility, you will have more trained staff that can become also very useful during a pandemic. It can become cost saving, and it fosters integrations of different programs into one platform. And the last advantage of having seasonal influenza vaccination programs is that it increases pandemic preparedness. So if you are used to purchase, if you are used to deliver, if you are used to monitor the impact of the vaccine, if you are used to monitor the impact of this vaccine, certainly the country is overall better prepared to mobilize this knowledge and this mechanism to respond to a potential pandemic. And we have seen it also for the COVID-19 pandemic. In fact, several countries that had seasonal influenza vaccination programs prior to the pandemic, the COVID-19 pandemic, were better able to procure and deliver vaccine during the COVID-19 pandemics. Next slide, please. And so we have been talking about how to estimate a disease burden, which is usually implemented in a study fashion. Where at PISA, that Cedric presented already, is an ongoing monitoring of the activities of influenza in a given season as compared to what was observed in previous season. Burden of disease studies are usually done over a specific study period, maybe over a 3 or 5 year study period, and then repeated thereafter. But what it is burden of disease estimation? So I mentioned already that the aim of estimating the burden of disease is really to estimate the total number of illness caused by influenza virus in the country in a given season or in a given year. And this is somehow the schematics that is presented in these slides, where the burden of influenza is usually represented as a pyramid, where at the bottom of the pyramid, represents infections due to influenza that results in mild and moderate illness. And this stays at the bottom of the pyramid not only because the clinical severity is the lowest, but also because the number of illness is the highest. In other words, following influenza virus infections, the most common clinical outcome, is a mild and moderate illness, which lasts for a few days and then it subsides. Nonetheless, because the number of mild and moderate illness is so high, it still constitutes an important impact of the health of people, but also on the cost. Because some of this illness will be treated in clinics, some of this illness will not be treated in clinics, but still represent potential out-of-pocket expenses for people that are infected. Then the second layer of severity in the middle of the schematics represent the more severe illness, usually referred to as hospitalizations. So a certain proportion of influenza virus infection result in severe illness that warrant hospitalization. And this is the middle layer of this pyramid. And then fewer cases, but still an important number usually, but fewer cases of influenza virus infections results in death. And this is the top of the pyramid in these schematics. Now, as you can see, the number of illness due to influenza can be substantial. It is across level of severity from mild, severe, and deaths. But then usually what we have in our setting, in our country, is Sentinel surveillance, which is surveillance that is implemented in a small number of Sentinel hospital or Sentinel clinics. And so the number of influenza positive specimens that we get from this surveillance system is certainly not reflective of the total burden of influenza disease in the country. So how to estimate the disease burden? Well, WHO has developed several methodologies and several tools to help country to leverage their Sentinel surveillance data to obtain what is schematically reflected here in this slide as the burden pyramid of influenza. And if you look at the middle layer of this pyramid, you will see different dots. The white dots represent hospitals in the country that do not implement Sentinel surveillance, and the red dots represents countries that do implement Sentinel surveillance for SARI in this particular case. So we are talking about hospital. And so WHO has developed a manual that assists country to estimate the incidence and the number of influenza-associated hospitalization from the Sentinel side, which is usually the very first step that is needed to build upon to subsequently estimate the full burden pyramid. I'm not going to provide any details on how this is done because it will require almost 2 days of training to go through the whole material. And AFRO has been implementing excellent regional trainings to show country on how to calculate the incidence and the number of influenza specifically at the Sentinel site. But for the purpose of this presentation, I just want to say that there are manuals that help country to achieve this first step. Next slide, please.
So Stefano, just to point out that you have less than a minute remaining in your subsequent slides.
Yeah, thank you. The next step is really to extrapolate the incidence that we have obtained at the Sentinel site to the national level. And so to understand really what's the total number of severe illness that is occurring in the country, starting from Sentinel site. And also for this, the WHO has developed a specific chapter in addition to the manual that I referred to before that can help country to do that. When this is complete, so when you have the total number of hospitalization in the country, then we can try to understand what's the burden of mild and moderate illness and deaths, which is the third step. Next slide, please. And this can be achieved through a web tool that has been developed in collaboration between the Johns Hopkins University and the WHO that allows to estimate the number of deaths and the number of mild and moderate illness after you have estimated your severe illness, so the number of hospitalizations. And these at the end will provide a much better picture of the total number of illness that are occurring in the country. Next slide, please, which is my last one, which is thank you all for your attention.
Thank you very much, Stefano. I can see in the comments that there are a lot of interesting questions and remarks pertaining to these two presentations that you and Cedric have made. So in the interest of time, we will not have our poll just yet, or our discussion, but do keep the questions and any concerns and remarks coming through the chat box. We will invite at this juncture South Africa to present on their experience where using PISA and BOD data is concerned, particularly how they've managed to harness this evidence for public health actions for preparedness and response. Jackie, the floor is yours.
Thank you very much for the introduction, Linda, and thank you, colleagues, for the opportunity. So I'm going to just start off with a quick summary of our surveillance programs in South Africa, specifically what we use to inform our PISA and burden estimates. So we have three main programs that we use, and these include both surveillance of the public and the private sector. I just want to double check, I'm still clearly audible?
Yes, loud and clear.
Okay, fantastic. So our first program, the Viral Watch program, that's a very long-standing program. This is private general practitioners that do surveillance for us. And we use this program specifically to look at vaccine effectiveness estimates and also to track the season over time. It's funded mostly by the National Department of Health. Then our other two programs are focused in the public sector. So this is influenza-like illness surveillance in public health clinics, as well as pneumonia surveillance in public hospitals. And these two platforms we use to look at trends as well over time, with the added benefit that we can look at risk factors for infection or for disease at least, and we can leverage these platforms to also look at our burden estimates. Now, we make use of FluNet, FluID, and PISA, where we upload our data weekly on a Thursday afternoon or Monday morning. And just to mention that we've built this into our work process flow to make sure that it is done routinely each week. And we report the data for the entire year up to the previous week. And I've just included a screenshot here from how this data is represented on the WHO page. So the use of these tools, because it's very important that we not just do surveillance for the sake of doing it, but this needs to be data for action and to drive policy. So firstly, in our weekly reports, we include the PISA trend plots as well. So this can help us to look at the timing and the severity of the season. So on the right-hand side of the slide, I'm showing just some extracts from the weekly report that we publish. The top two graphs, this is influenza. We look at transmission. So this is transmission, and that's from our ILI-like surveillance, so both on the general practitioners and the clinics. And then on the second graph, we have morbidity and mortality. So this is where we look at inpatient pneumonia. And we can see in these examples, the hard line, that is our current year, the dotted line is the previous year. And then, of course, we have the different thresholds that we're all very known with. I've just updated the colors a bit to look at the severity of the season. And to mention, so in South Africa, we use 2022 to 2024, to ensure that we don't include the pandemic period that might skew our thresholds as well. Then we also look at RSV morbidity and mortality. This is children less than 5-year-olds with pneumonia in public hospitals. And lastly, we've more recently also started including SARS-CoV-2. For this, we don't use MEM, we use the mean standard deviation method as described in the PISA documentation. And this is helping us to see that we really are just seeing low-level circulations of SARS-CoV-2, as you can also see from the plot. Now, the important part here is we can use this information, firstly, look at timing and the severity of the season to know at which point we need to react, when we need to be actively communicating to both our population, to answer media queries, and this can also help us in vaccination campaign messaging. Then away from PISA, but going more to what Stefano spoke to, and that's the burden estimates. In South Africa, we've published burden estimates using our surveillance for influenza, for RSV, and for pertussis. And with the fact that we are doing our pneumonia surveillance, we're doing clinic surveillance or ILI, and we also have other resources that we use to build this burden pyramid, as Stefano has alluded to. I just don't have time to go into all the sources. But then this is also information we can use to drive policy. So for example, our influenza burden estimates we use to inform our influenza guidelines and to set priority groups for vaccination. Our RSV burden estimates, we can use that now to advocate for interventions as maternal vaccination and monoclonal antibodies for infants become available. And for pertussis, these burden estimates were also used to advocate for maternal vaccination. And we have that now that's been incorporated since 2024. And we have boosters at both 6 and 12 years as part of the EPI. Then we are also in the process of working on updated burden estimates for influenza, RSV, and SARS-CoV-2 post the pandemic period. So just as I end off, so some achievement and best practices. So the beauty of our systems is that it's long-standing, it's robust, and it's scalable. It was very easy in 2020 to bring in SARS-CoV-2 to start testing for that. Because we're doing year-round testing as well, we can look at the season timing, we can identify if there's issues like we have out-of-season circulation, and we could very clearly document how influenza and RSV circulation declined during the beginning of the pandemic. It allows us to characterize our viruses, and we are actually moving towards a different lab assay that we can also include more pathogens, and we're hoping to start putting that into our reports soon. Now, just to stress again, surveillance is data for action. We can't just be collecting this data and not using it. So we've been using it for weekly reporting. We provide annual summaries as well. Again, important to share with our policymakers to drive public health policy. And it's important to also make the most of the investment. So we identify key data points that we need to collect as well to not just track the season, but get vaccine information so that we can get vaccine effectiveness estimates that's shared with GIV. We do virus isolation and share specimens with the WHO CCs. We can look at risk factors and burden as well. And then lastly, and this is more of a best practice point I just want to make, it is really critical to look at your data in real time, to both identify issues, so do data checks, and to share the data in good time. So our laboratory are able to do testing in real time. And then from the EPI side, we've set up automated processes that we can, on a weekly basis, do data checks to confirm data integrity, identify any issues in enrollments or data collection in a timely fashion, but then also to have these regular reports. And that also relieves the burden if we are submitting to FluNet, FluID, PISA. This is all automated, so it's really quick and easy. You run your report, you check that everything is good, and you can upload it to make sure that we can continue to report in a timely fashion. And that's it from me. Thank you very much.
Thank you very much, Dr. Jackie, for your very interesting presentation. It's quite interesting to see the surveillance data to drive policy, but also how you've managed to integrate other respiratory viruses in your surveillance. Just one quick question. Could you please share a recent example where surveillance data directly influenced national preparedness or response in South Africa?
So the example I would like to mention here is just the pertussis work we done. So this is now a bacterium that's added onto our surveillance, and really with getting these burden estimates out, we were able to change the EPI schedule, so our vaccination schedule in children, to also add in the additional booster doses and maternal vaccination. So that's just one of the examples, and then of course we can also use our data. We look at risk factors for severe disease for influenza, and with that, we can guide who should be prioritized for vaccination. Because more than 40% of our population actually falls into categories as well that needs to be vaccinated according to WHO guidelines. But with this, we can try and identify what's the highest priority to make sure with the limited doses we have, we do cover who we need to do.
Oh, thank you very much. So while our colleague from Algeria is preparing himself for the next presentation, I would like to ask all the participants if they could type in the chat box what barriers are preventing you from consistently using the tools like burden estimation or threshold setting. If you could write in the chat box. And I would like now to invite the colleague from Algeria, I think Dr. Nassim Ayad, for your presentation. Over to you.
Thank you giving me the floor. Can you hear me?
Yes, loud and clear.
Yes, we can.
Can you see my slide?
Yes, put it in presentation mode.
Okay. It's okay.
Perfect. Perfect.
So, hello everybody, and again, thank you for giving me the floor. So, my name is Nassim Ayad from the Laboratory of Modeling and Biostatistics from the Pasteur Institute of Algeria. And today we're gonna show you our small or modest experience in influenza and other respiratory virus surveillance. So, we jump to slide. So in Algeria, Sentinel surveillance for influenza was established from 2007. Currently, we have 10 Sentinel sites with 6 actively reporting this year. Our surveillance covers ELI, SARI, COVID-19, and other respiratory viruses. So we are reporting to FluNet and FluID every week. Completeness rate for the last 12 months was 100% to FluNet and 60% to FluID. Timeliness rate for the last 12 months was 90% to FluNet and 10% to FluID, averaging mainly 3 days of delay. So we can see in the graphic of submission trends that report submission was consistently high between November and April and decreasing from May. This diagram shows how our influenza surveillance system works. Sentinel physicians send weekly reports and samples to site coordinator who forward biological samples to the National Influenza Reference Laboratory for PCR testing and report to Laboratory of Modeling and Biostatistics for statistical analysis. So virological results are then transmitted to the Modeling and Biostatistics Laboratory where weekly analyses are produced. Those analyses are shared with public health decision makers in Algeria and uploaded to international platforms like FluID and FluNet for global data sharing. We are here the updated bar plot of weekly influenza detection by subtype and positivity rate in Algeria. Up to now, we are in week 33. We have, for example, also weekly trend in positivity rates by respiratory viruses. We have influenza viruses, SARS-CoV-2, and other respiratory viruses. So we can see the trends in the curves updated up to now. At least we have some achievements and best practices. We have regular weekly reporting, standardized electronic tools improve data for improving data quality. We have weekly analysis shared with decision makers, data uploaded to WHO FluID FluNet. And as achievements, we have peak alerting system established, improved timeliness of reporting, better coordination between clinician and laboratories. But we have some lacks. For example, limited coverage, only part of wilayas or provinces participate, only one laboratory analyzing samples. And we propose to expand for the next year participation to more provinces and strengthen diagnostic capacity with adenovirus laboratory. I think that's it, and thank you for your attention.
Thank you very much, Dr. Nassim. I think this is a very good practice of linking AP and virological data from point of collection to reporting. Are there any questions from the assistants? I've noticed there was a question to Jackie. Is Jackie still around? If you could maybe, oh no, I think the question is no longer. Was it answered?
I just answered. I replied
okay.
on the chat.
Okay, for the benefit of all the participants, could you just take the floor?
Oh, of course. So the Viral Watch program that I mentioned is in private practitioners. So we onboard private general practitioners who then we send kits to. So it's completely free of charge to them and their patients. When the patient have influenza-like symptoms, so cough and fever, they do a swab for us and then send that swab to us. That swab comes to us either through help with the private labs or through our national service. So we work very closely with our private labs and the GPs to be able to do this. And then we can test it at NICD. So we have a short CIF to also get vaccine history and underlying conditions. And then that actually helps us to calculate the vaccine effectiveness. Over.
Thank you. Dr. Nassim, could you please elaborate more on how your country was able to integrate AP and virological data from collection to reporting?
I think that I shared the slide, a diagram how we work in Algeria. We have Sentinel centers. We have about 6 active this year, and they share data, the reporting data, and also they transmit the samples for virological analysis. And
okay. Yes, go ahead.
Hello?
Yes, go ahead.
Can you hear me?
Yes, I
Yeah.
can hear you.
And we have Sentinel. We have biological sample analyzed in the National Influenza Reference Laboratory for PCR testing, and the reports are transmitted to laboratory of modeling and biostatistics for statistical analysis. So every week we did statistical analysis and updated curves and bar plots and some key results we sent to policy makers in Ministry of Health or and policymakers in Pasteur Institute of Algeria, and we share also in the FluNet and FluID platforms every week.
Thank you. Thank you very much. Before we proceed with the remaining presentations, may I invite Sanga to pull out the poll, please? Over to you, Sanga.
So a link has been shared in the chat box. We are kindly asking participants to just either click on the link or scan the QR code that is presented on the screen. When you do that, you will be able to see the question which is being asked and put in your answer that fits mostly your country situation. Okay, some responses have started to come in. Can we all just try to follow the link or scan the QR code and respond to the question that is asking which denominators are routinely available at your Sentinel sites? Okay, thank you for those responses. Can we have the second question, please, Sangha? Okay, we see the responses coming in. Thank you very much. Maybe we can have the third question and then we'll move back to the presentations.
Yeah, so those are things I think should come up with.
All right. Thank you very much for the responses that you've shared. They're very insightful in that they give us a context of some of the challenges and some of the strengths that the different member states may be experiencing. So at this point, we have two more countries that we wish to spotlight. There is Zambia and Nigeria, but I think Zambia will be coming in first. I just want to emphasize to our presenters that our presentations should adhere to the time limit, which is strictly 5 minutes. So if we can have Zambia presenting. Dr. Paul, please go ahead.
So, for thank you very much. Can you hear me? I'm going to
Yes, we can.
I'm going to give a summary presentation from the National Influenza Center, Zambia. My name is Paul Simsika. Next slide, please. So this just shows the overview of the national surveillance, RSI Sentinel surveillance system in Zambia, established around 2008. The target population for the surveillance is obviously all ages, and we do this in selected Sentinel sites where we target clients with ALI or SARI, which includes ALI plus hospitalization. And then we also look at the PUI, persons under investigations, and we've also recently introduced the extended SARI surveillance in our two pediatrics hospital with the sole purpose of establishing the burden of RSV so that we can have a case of introducing the approved maternal vaccine for RSV. So those are the sampling numbers. So for ALI, we target the first 5 samples in a day. Then obviously for SARI or the severe cases, we try to sample them. Then approximately in a year, we are getting about 500 NP or OP swabs. So that is the laboratory testing. Those are the targets that we look at, and then the reporting obviously is shared to partners, stakeholders, and FluNet and FluID. Next slide, please. So this is just showing the location of our Sentinel sites, strategically located in wider places that includes the tourist destinations in border areas and also in mining towns. So these Sentinel sites have 2 types of surveillance, that is the ALI and also the SARI. So the ALIs are usually located in the urban centers and clinics where the majority of the population live. Next slide. So this is just show the reporting status for the in the FluNet, FluID, and the frequency. So this is done weekly. We try to do this every Thursday. So what we are reporting to the FluNet, the FluID, and also the PISA. Next slide. So this is just shows the dashboard as obtained from WHO, the FluNet. So these are the numbers of the samples that we have uploaded as updated. I think should be last week, and then the down figure basically shows the SARI syndromic data. So these are the hospital the hospitalizations and also the hospital visits. Next slide. So this is the surveillance architecture. First, we wanted to speak to what is available at the National Influenza Center in Zambia. So I've got the computer servers, I've got handheld devices strategically introduced in selected facilities to capture CIF. And then also have external servers, and also we have introduced the ScanForm technology in the sites that we conduct extended SARI surveillance for RSV. Internet connectivity, I've got the program, the LAN, and then the WAM servers for DHS2 application. I must also mention DHS2 application has also been introduced recently, but this is done also in some specific sites. So this is done also in parallel with the paper-based system using the CIF as adopted from the WHO system. So that is the laboratory capacity. We've got 4 RT-PCR machines, 1 automated extractor, and also we are doing genomic sequencing using the ONT. So that is a human resource currently available at the NIC. Next slide, please. So this just shows the surveillance architecture of how everything just fits in together. So first we have the hospital admission data and the visits. So hospital admission data is collected through the records from the hospitals, and the visits data is usually collected from the ally sites. And then this is accompanied by CIF data. Like I mentioned earlier, so we've got the paper-based system. So all this data is then captured and transported and then stored into the surveillance data system at the NIC. Then on the other hand, we've got the handheld devices, which is the phones and the tablets. So what happens is that the surveillance officer in the Sentinel sites, they take a screen of the CIF, and then immediately this data is sent to the central server at the NIC, where there's some data processes, which includes cleaning and using the other data pipeline, and then the main data is stored in the repository. So after that, then we have got we are able to use the dashboards as generated through the GHS2 tracker for site reports, and also we use this to visualize indicators, and also we use this to be able to inform and give feedback to the surveillance sites in case we are seeing inconsistencies in the data that is being shared. We also use the same data to extract and run analysis and presentation reports, which are regularly shared with our partners. Also, we do routine monitoring and sample collection. Next slide, please. So this just shows our achievements and best practices. So what we have noted is that as part of our achievement is inclusion of this hospital data. Hospital data collects for recording syndromic data from the clinics, hospitals, seems to be working very well, even though we have noted some inconsistencies in this space. Also, adopting automated data screening processes using the RS software to report seems to be something that is working very well for cases meeting the ally and SADI surveillance. And also using the R code automation for data quality checks has proven to be a good practice, as we are able to use this to be able to note the inconsistencies or maybe perhaps mistakes that are being done, and then immediately be able to provide feedback to the Sentinel sites for continuous improvement. We're also using the RSP-MET. The RSP-MET has also proven to be user-friendly for uploading of this data. I think this should be my last slide. Thank you very much.
Thank you very much to our colleague from Zambia for that clear and insightful presentation. Thank you again for highlighting the good practice of linking AP and biological data, which is a foundation for using the available epidemiological tools that are available. We will now move on to hear from Nigeria, and I would like to kindly remind the presenter to please keep the intervention within 5 minutes so we can stay as close to time as possible. That said, I would like to apologize in advance to participants and our interpreters, as we may run 10-15 minutes over our originally scheduled end time. We appreciate your patience and understanding, and thank you for staying with us. Nigeria, the floor is yours.
All right, thank you. Thank you so much, colleagues. Thank you for the opportunity. Please kindly confirm if you can see my slide.
Yes, we can see your slide.
All right, thank you so much. My name is Dr. Zorotodomo Philip. I work with WHO Nigeria as a state coordinator and pandemic influenza preparedness focal point. I'm going to be presenting Nigerian Spotlight presentation on behalf of the country. And thank you so much for the opportunity for Nigeria to take part in this presentation. All right, this is the map of Nigeria showing the various Sentinel surveillance sites in Nigeria. we have a total of 10 Sentinel surveillance sites in Nigeria. They are distributed across different geopolitical zones. We have one in the northeast zone of Nigeria, in Maiduguri. The one of the northwest is in Kano University Teaching Hospital. The one in Abuja are in 5 places. We have one in Asokoro District Hospital, Maitama District Hospital, Nyanya General Hospital, Bwari General Hospital, as well as Mogadishu Barak Hospital. Then in the southwest, we have it located in Lagos State University Teaching Hospital. In the south, we have it located in Akwa Ibom General Hospital, Ikotekpene. In the southeast zone, we have it in Nnamdi Azikiwe University Teaching Hospital. So the total population of Nigeria is 237.5 million. So the Sentinel sites are located in various zones to be able to cover this population. And the sites are 10 in numbers. The Sentinel surveillance in Nigeria commenced in 2011. The types of surveillance we conduct are influenza-like illness, severe acute respiratory infection, respiratory syncytial virus, COVID-19, HMPV, and others. Now, for the virological data, this is the way we are faring. Cumulatively, in 2025, from week 1 to week 32, we have 2,252 cases reported, and investigation has been conducted for 2,179. The remaining are undergoing testing, and we are able to isolate 100 cases of influenza, normal flu, from the investigation conducted, and we were also able to detect about 49 cases of SARS-CoV-2. Then the fluid ID data we are also reporting, though sometimes we have challenge with the colleague that is reporting on behalf of the country. So WHO used to follow up with the focal point from the Nigeria Center for Disease Control and the Federal Ministry of Health to make sure that the colleague is reporting timely. All right, this is just a slide showing some of the activities we conducted, supportive supervision to the Sentinel sites. So for the supportive supervision to the Sentinel sites, we aim at engaging the site management as well as the State Ministry of Health to support in ensuring that colleagues are reporting are searching for the cases from the GOPD and from the ward, and they are reporting the cases. And when they don't do that, our colleagues are from the State Ministry of Health should be able to reach out to them to remind them, considering the fact that our colleagues are from the national level will not always be available at every time. Sorry, my slide is not moving. I tried to move it. It seems as if it's difficult to move. I don't know what's happening. But can we see it?
Yes,
Yes,
Dr.
we can
Philip,
see.
All right.
we can see the achievements.
All right. So here we have the number of cases reported in Nigeria from 2018 to 2025. So from 2018 to 2025, you will discover in 2025, the total number of cases reported are 2,252, far more than the cases we reported in the previous year. And then for SARI, we reported about 320 cases. Is an indication that we are improving in our case detection and reporting, both in the Fluid ID and the FluidNet platform. All right. We also had capacity conducted in the lab to be able to strengthen the capacity of our workforce in the lab. We have 10 of them. And NCDC was able to mobilize additional 5 people that are working in the bench and in the lab to ensure that samples that are coming from the various Sentinel surveillance sites are investigated. So the capacity was built, supported by WHO to make sure that that training was done. They appreciated the training, and they are also looking for more opportunities from time to time to refresh their knowledge. All right. So some of the achievement we've been able to achieve, advocacy and stakeholders engagement. We conducted to the various states where these Sentinel sites are located, and across the 10 Sentinel sites, we were able to conduct advocacy to the management of the hospital. The essence of this is to tell them of the importance of reporting. The fleet ID are reported from the Sentinel site to the focal point in NCDC. So from time to time, they have challenges reporting. So engaging the management to make sure they are reminding them on weekly basis to be reporting will enable the focal point from NCDC to be reporting on the fleet platform, and then the virologic data, as soon as the samples are collected, they should be shipped to the National Reference Lab for investigations to be conducted. And once the result is ready from NRL, they send the result to the various Sentinel sites, and sometimes they share it with the clinicians at the various Sentinel sites. They also use it for decision making. Also for training, we train over 100 people at the various Sentinel sites to build capacities. One of the challenges we used to have is after training some people, they will have impression that they will be giving some stipend. But when they start the work and discover their expectation is not met, some of them opt to go to other places. When they get a better offer, they tend to leave. So when we get new people that replace them, we use that opportunity to build their capacities. And anytime we are having that training, we also advocate to the management of the hospital and this team to invite more people that are willing so that we can build their capacities. In case of attrition, we can have enough pool to be able to replace. Then we also supported them in procuring VTMs and swabs to be doing their testing. That has been a challenge, and some sites for some weeks we are not able to test. So WHO was able to provide over 1,000 packs of VTMs and swabs. And we also had support from AFRO that was deployed to the various Sentinel surveillance sites. And that has really helped them to be able to reach the number that they are able to test. Then we also have bi-weekly meeting. That coordination meeting, we ensure that our colleagues are from the National Influenza Sentinel surveillance site are part of the meeting. We get feedback from them, and we also provide feedback from the national. If they have challenges, they share it during that meeting, and we provide solution and find mitigation measure. Also, interdepartmental meeting also take place at the various Sentinel surveillance sites. We've encouraged the site coordinators and the members to make sure they use the opportunity of those clinical presentations to be reaching out to other colleagues to sensitize them on the influenza as a way of building capacities, public health capacities in line with the international health regulations. So let me just end by appreciating the opportunity for this training, and in line with the international health regulations and the pandemic influenza preparedness framework requirement for country to develop, strengthen, and maintain public health capacities. WHO Nigeria and partners who work with the Federal Ministry of Health, Nigeria Center for Disease Control, and other health department and agencies to build the required core capacities. Part of the things we are doing in the pandemic influenza preparedness is part of the core capacities we are building. So this summarizes some of the achievement we have. Sorry, some we couldn't mention them because the time is limited and the number of slides was very small that we are requested to prepare. So thank you for the opportunity over from my side. Thank you.
Thank you very much to our colleague, Dr. Zorto from Nigeria, for that valuable presentation and for keeping to time. Much appreciated. Before we move to the next presentation, I would like to ask Sanga if she could project the poll survey. I would like to invite all participants to take a quick poll survey now on your screen. This will help us gather your perspectives and better tell our upcoming discussions. Sanga. Perfect. So you may want to click on the link or scan the barcode as we did previously. 1 more minute. Sangha, may you please move to the next question? Thank you very much. I think most of the participants have already responded. Quite clear that we need support for Flu ID and FluNet. I would like to encourage you, if you have any questions, to raise your hand and take the floor. I'm not seeing any hand raised, nor are there any question in the Q&A box. We will now move on to the next presentation from Linda, who will provide an overview of the status of the integrated respiratory surveillance in the region. This is a crucial area as we work to strengthen routine surveillance and improve early detection and response capacities across countries. As mentioned earlier, while today's presentation will focus on the broader surveillance context, a dedicated session on the RespiMat platform will be organized soon to provide more in-depth and hands-on support. Linda, the floor is yours.
Thank you very much, Lionel. It was really great hearing from the countries, and we had hoped that we would go through RespiMat as indicated by Lionel, but I think with the time limitations we have, that may not be possible for today. Sangha, can we please have slide 78 being projected? All right, thank you very much. So I will be touching on the regional overview, particularly just looking at how far we have come, where the issues to do with our surveillance are concerned. This pertains to the countries in the region that are currently conducting influenza sentinel surveillance, as well as those that have moved on to be either reporting to PISA, conducting BODs, and reporting to both FluNet and Flu ID. Next slide, please. So just a snapshot. To date, we have about 33 countries out of the 47 member states in the AFRO region reporting virological data via FluNet. Of these, 16 report epidemiological data via FluNet. There have been 12 countries that have conducted burden of disease estimates, with 7 of those having been trained in the last 2 years. Of these 7, 3 are currently developing manuscripts, and the hope is that by the end of the year, they would have finalized their burden of disease estimates with some publications. So this will really move us forward as a region in terms of having a clear picture of the burden of disease. And this is something that was highlighted as a key strategic focus area in the earlier remarks by the program area manager, Dr. Chamla. We have 1 country that is currently working on the economic burden of disease estimate, and 8 of the countries here have been trained on PISA, and 3 are currently reporting. It's interesting to see some of the comments that were coming in. I think we are taking note of the areas that we need to provide additional support. I acknowledge Zambia has indicated some concerns. South Sudan has expressed interest. And if there are any other countries who would also benefit from using some of these tools, please kindly indicate in the chat box, and we will provide further support and additional engagements. Next slide, please. So, having gone through this webinar, the key message is that we really want to be able to guide our strategic focus where data for preparedness is concerned, that it starts with timely, consistent virological and epidemiological reporting. This really is the foundational block. And in the upcoming year, our focus will be on incorporating the latest guidance on surveillance, and this includes the integration of influenza sentinel surveillance beyond just a singular disease or virus, but to also incorporate RSV, SARS-CoV-2, which I believe most of the member states are already doing. We will also focus on capacity strengthening and uptake of the available tools that have been developed by WHO and that are being used for the estimation of the burden of disease, the threshold setting and PISA framework, as well as improving routine epidemiological and virological reporting of our Sentinel surveillance data. The goal is to ensure that the surveillance outputs directly shape policy and programming through issues to do with seasonal vaccine policies, risk communication, and overall pandemic preparedness. Next slide, please.
Maybe for someone in DRC, there is a signal.
So what you see here is just an illustration of how all of the work we're doing and the discussions we've been having today fit in together. At the base, which forms the foundation, is the routine sentinel surveillance. In a lot of the instances, member states have asked, what does this data mean to us? How can we harness it to be able to draw meaningful insights from it and to be able to advocate for resource allocation? Through these building blocks, we are able to use this to inform public health preparedness and response actions, to be able to advocate for various policies that include vaccine policies in order for an evidence-driven programming. So as you can see here at the base, we have our routine surveillance, which is what we are doing on a day-to-day basis. And from there, we will then be able to build into setting thresholds, estimating disease burden, and ultimately creating more resilient health systems that are prepared for the next pandemic. So this is the end of my presentation, but I would just like us to have some comments or questions regarding this session that we've had. I'm sure we've run out of time. We're 10 minutes over, but we probably still have a minute or two to invite any questions, comments, and if any areas of support, kindly indicate in the chat box so that we can take note of this. Okay, I think the questions that were indicated in the chat box were addressed. I do not see any outstanding questions. If there are any, we can raise our hands one more round before we close off the webinar. All right. Thank you very much, colleagues. Thank you to the organizers, the panelists, the presenters from the country spotlights. We also would like to thank all the participants that have joined, and we apologize for exceeding the stipulated time. We also apologize for not being able to go through the Respimat presentation and demo, but we will be in communication. Please note that the recordings and all the materials of this webinar will be shared with you in the next few days. Thank you very much for your time. Bye-bye.
Bye.